We live in really exciting times. I remember in a talk once somebody saying, well, look, it's far better to have lots of exciting things in the cupboard than an empty cupboard. It, of course, is very challenging when we've got drugs that are just about available, but we're struggling to get them to our patients. And it does make us all reflect, clinicians, patients, I'm sure regulatory authorities as well, as to how we can best use what we have available and best use the resources within the NHS. Because it's a challenge. These new drugs, they cost huge amounts to develop and put through clinical trial programs. Of course, that is correct. And the companies who are marketing them, they are, of course, businesses. They have to make profits. And this feeds through into organisations such as the NHS that have got to pay the bills and get the drugs to our patients. And the question is how we navigate through these challenging obstacles. And really, it splits depending on the type of drug, the indication, the trials that have been developed. So on the one hand, Ibrutinib, which, as you know, has now come through the system. We have nice approval in the relapsed refractory setting and in the TP53 dysregulated setting in the first line. And so that drug's come through a pretty rigorous phase 3 trial development program. We've got clear survival benefits. It's been challenging because patients have done so well. So if you're a pharmaco-economist, it's been hard to actually calculate what the true cost to the NHS will be. You could say, of course, that's a great problem to have, but that has set its own challenges. But obviously there are negotiations going on behind the scenes that we as clinicians probably shouldn't know anything about, because we need people who can just set the costs and what is appropriate for relative clinical gain to have those negotiations and say, yes, within the NHS framework, this is cost-effective, value for money, and you can use them. Of course, the challenge comes beyond that when you have drugs that have not got randomized data, that particularly if in other parts of the world they've been given accelerated approval. There are occasional examples where in the US it's approved significantly in front of Europe. Venetoclax is a good example, which has now been approved both in the US and in Europe for specific indications, and those are 17p deleted or TP53 dysfunctional CLL, where idelalisib or ibrutinib, or sorry, I should say B-cell receptor pathway inhibitors, are inappropriate, or in the relapsed refractory setting in patients who've had chemoimmunotherapy and had a B-cell receptor pathway inhibitor and then progress. And so the licensing authorities have made these decisions not based on randomized data. And this creates problems for the regulatory authorities. It's hard for them to work out relative benefit. It's hard for them to work out which patient populations in the UK match the populations that have been used in the trial. And it's challenging all round. In January this year, I was the independent expert for the NICE committee looking at the indications of Venetoclax and CLL. And it clearly caused many challenges for the expert review group, as it does for the company, that you end up with relatively small data sets showing remarkable benefit. Now, of course, if you're a patient or if you're a clinician treating CLL, we are naturally convinced by small data sets showing remarkable benefit, particularly in the relapsed refractory setting. And I think this is one thing that harks back to our UK experience with Ibrutinib in the compassionate access scheme and looking at patients who came off Ibrutinib with progressive CLL. And we've seen, of course, it's small data and it is in effect at the level of anecdote, but we saw every patient that progressed with CLL in the first year in our data set has now died. And yet beyond the first year, access to Venetoclax means that we've got quite a collection of patients in our data set now who are alive on Venetoclax, and we have them in our clinic. Because the AbbVie, the company, made Venetoclax available through the Early Access to Medicine scheme with NHS England. Now it's got a license. The company is still allowing individual cases on compassionate access. So we do currently have a slightly unsatisfactory way of getting hold of the drug, which is allowing us all to get hands-on experience. So not just people like me and other trial centres have used the drug in trial, but people are also using the drug off trial and seeing how efficacious it is. So of course that creates its own problems, because we are seeing how good this drug is, but are we generating data that's going to allow our purchasers to say, yes, you've demonstrated value, and therefore we can use that to get the drug into the clinic. So there are many challenges. I, of course, cannot provide simple solutions, as no individual can, but we certainly need to work with our patient groups. We could do better working, I think, on quality of life issues and really persuading the patient, the purchasing authorities, the commissioners, how much real benefit there are for some of these new drugs and how the world genuinely has changed. The new drugs really have changed how we're able to manage our patients and completely changed the outlook for some patients in very difficult clinical situations.